It's 10 past by my clock, so we'll get going. We'll start off this session on genomics and COVID with our first presenter, which is Carolyn Vartanian. I hope I'm getting that right, Carolyn, from Cancer Australia, who'll be talking on COVID recovery and implications for cancer care.
Thanks, Megan. Am I on?
Yes.
Great, thank you. Hello, everybody. I'm Carolyn Vartanian from Cancer Australia, the Australian Government's National Cancer Control Agency. I'd like to begin by acknowledging the traditional owners of the respective lands from which we are joining this virtual event and pay my respects to elders past, present and emerging. And as Megan said, today I will be speaking about Cancer Australia's COVID-19 recovery program of work, which explores approaches to supporting high-value cancer care in the recovery phases of the COVID-19 pandemic. Social distancing and quarantine measures employed in response to the pandemic have challenged the delivery of cancer care and led to potential delays in cancer diagnosis and treatment. Cancer Australia has recently reported on these delays for 5 prevalent cancers. These delays are likely to impact cancer outcomes, the cancer workforce and cancer services. However, the pandemic has also provided opportunities for improvements in cancer care. As we are now well and truly entering the recovery phases of the pandemic, Cancer Australia has considered aspects of cancer care that have changed during the pandemic and new or modified approaches to care that are of high value and should ideally be retained after the pandemic, not only to improve the quality of cancer care, but its resilience well into the future, particularly in light of any further infection spikes and lockdown. Informed by national and international literature and feedback from key opinion leaders in the health sector in Australia, including consumers, we've identified 12 elements of cancer care that changed during the pandemic, and they're there on the slide. Today, I'm just going to talk ever so briefly about 3 of them, which outline new or modified models of care. In relation to each of the 12 elements, we considered what changed, what was the impact of the change, both its benefits and challenges, and we identified strategies at the system, service practitioner and patient levels to further enhance or embed high-value changes to cancer care. These strategies are intended to be used by a range of cancer control stakeholders, including health services research, as many of the strategies still require ongoing research and evaluation. The COVID-19 pandemic prompted an accelerated yet longer-awaited uptake in telehealth across the whole healthcare system, and this was in part facilitated by the expansion of the telehealth MBS item numbers. The impact of this change for cancer care was that telehealth supported the continuity of cancer care throughout the pandemic, helping to reduce exposure to the virus for clinicians and patients, particularly those who are immunocompromised. It also enabled choice and convenience for patients, especially those living in rural and remote areas, as they were less likely to want to or even be able to travel to large city centres for specialist care. There were, of course, challenges, and we've heard a bit about this already today, in implementing telehealth, and many of these relate to the lack of appropriate infrastructure, capability and training for both clinicians and patients. And all of these challenges require further services research as we continue to utilise telehealth in cancer care, and it's become even more pressing now that the expanded MBS items have become permanent. To ensure that telehealth models of care are retained in the future, strategies to embed this high value change in care include, for example, at the system level, developing clear guidance, policies and procedures to guide safety and quality in cancer telehealth consultations, and a whole lot more work around the ethical, clinical and legal responsibilities of not only clinicians, but technology providers and health organisations. Also at the practitioner level, developing and distributing guidance for health professionals on the appropriate use of telehealth for cancer care, particularly, for example, in identifying which consultations across the cancer care continuum should be held face-to-face and not by telehealth. And for example, that might be a consultation that requires delivering some bad news around diagnosis or prognosis. With increased pressure on the health system during the COVID-19 pandemic, some patients were unable to or were concerned about visiting their cancer services for their follow-up appointments. And the uptake of shared follow-up and survivorship care between cancer specialists and the patient's GP has in part helped address this problem. The impact of initiating shared follow-up care is that it allowed for continuity in follow-up care. And it also helped to increase the capacity of specialists to focus on patients requiring urgent care and to relieve pressure on specialist and hospital services more broadly. We believe this pressure will continue well into next year as new cancer cases may surge due to the drop in diagnosis and treatment we've seen through our analysis of the MBS diagnostic items. In our report, we offer numerous strategies to support broader uptake of shared follow-up care and survivorship care in the recovery phases, including the requirement to embed processes and templates to support development and sharing of patient follow-up care plans between the multidisciplinary care team, including the patient's GP. Supportive and palliative care also changed during the pandemic, and many face-to-face supportive care appointments were replaced with telehealth. In some states, home-based palliative care services were initiated or rapidly expanded to provide care to COVID-19 patients outside of the hospital. The advantages of these changes is that virtual supportive and palliative care enable safe contact between health providers and immunocompromised patients. However, socially distanced care limits the opportunity for hands-on care and can lead to care feeling quite impersonal for some patients. Again, we've offered multiple strategies to enhance these changes during the pandemic phases, including developing standardised policies and guidance for health services to minimise unwarranted variation in practice to supportive and palliative care, particularly during times of stress on the health system. So finally, the pandemic and the recovery phase continue to present opportunities for us to revise some healthcare practices in cancer care, and our full report, COVID-19 Recovery, Implications for Cancer Care, and some of the other reports I've referred to are available on the Cancer Australia website. Thank you very much.
Best unmute myself. Thanks, Carolyn. We have a couple of questions for you. So first one from Rachel is, have multidisciplinary team meetings been conducted using telehealth, i.e. the meetings between groups of cancer clinicians?
Yes, thanks, Rachel. That's Megan and Rachel, that's a good question. And we definitely identified that there was a move to virtual MDT meetings. Now, in some pockets of excellence around the country, that already exists. But we saw from our evidence and from our consultations with, clinicians on the ground that virtual MDTs became, necessarily more prevalent. And obviously we see that as a high value change. But, more work to be done around making sure that that process works and that, all the multidisciplinary care team members are able to connect either face-to-face or in a hybrid MDT, which includes telehealth.
Thank you. Could you tell us about any practical things that can be done to make distance palliative care more personal?
No.
So we've identified an issue with telehealth.
Yeah. Look, no, I can't sort of say here's the strategy, but we think that distance palliative care, from what we saw nationally and internationally, and of course internationally, this issue continues to be of relevance because of the ongoing large numbers of infection across, other countries. But, I think it's interesting for us to see whether distance palliative care returns back to the more face-to-face, hands-on approach now that Australia is at the moment essentially in recovery phase. I mean, we will continue to watch that space, because whilst we've released this framework and this report, Cancer Australia will continue to monitor it and update it, and we ourselves will undertake some activities in relation to some of the strategies to embed these high-value changes to cancer care.
Wonderful. Well, thank you so much for your presentation, Carolyn.
Thank you.
Might move on to our next one now. So we've got Marissa's slides up next, Sarah. Next, we've got Marissa Dickins joining us, who's a research fellow from Bolton Clark Research Institute. And she's going to be talking about telephone support during COVID, helping others with respect and unity. And have we got you, Marissa?
Slides are up, controls just being transferred.
Okay, and you're still on mute, Marissa.
Okay, there we go. Thank you. Hi everyone, my name is Marissa Dickins and I'm a research fellow at Bolton Clark, and I'm here to speak to you about our social support program called Hor-R-U that we're launched during the pandemic to keep our clients and residents socially connected. For those of you who may be unaware, Bolton Clark is a national provider of personal care, nursing and allied health support to 10,000 individuals in the community every day. It's also the home to almost 5,000 individuals in our residential and retirement living communities. You may know Bolton Clark by our previous names. They are RSL Care and the Royal District Nursing Service, or RDNS, and we merged a few years ago and were renamed as Bolton Clark. The Bolton Clark Research Institute, which is where I'm situated, is an academic research institute which is embedded within the business. We comprise of 10 enthusiastic researchers, the majority of which who are PhD qualified, and our purpose is to conduct and synthesize research with the aim of improving knowledge and practice in aged care. Let's see if this, there we go. And as you know, this year has been like no other. The COVID-19 pandemic has swept across the world, and stay-at-home orders and limitations on social interaction have shown to be effective at reducing transmission of the virus, as shown by lockdowns, particularly here in Melbourne. However, only an effective and well-administered vaccine will reduce the threat of COVID-19 completely. Statistics show that mortality from COVID-19 is strongly skewed to the older population and those with comorbid conditions. These statistics are a particular concern for Bolton Clark, as many of our clients and residents fall into both of these categories, and as such we are at high risk of developing severe illness from COVID-19. Many have chosen to follow the advice of the government to isolate or reduce the contact that they have with people outside of their home, including in some instances reducing the services that they're receiving. We know, however, that these measures have significant psychological, physical and economic ramifications that we must work to remedy. Before I move on, I'd just like to mention two concepts of social isolation and of loneliness. So social isolation is the objective experience of having few connections. People who are socially isolated interact with very few people in their day-to-day lives. Loneliness, however, is the subjective experience of being lonely or being unsatisfied with the social connections that you do have. And while these concepts are interrelated, they are distinct. A person can be socially isolated without being lonely, and a person can also be lonely whilst being surrounded by a group of people. During the pandemic, more people may be experiencing social isolation due to the restrictions. This is particularly true for people who are not comfortable with technology and unable to take advantage of tools such as video chat, which is, while it's not the same as face-to-face interaction, it can help people to make that kind of further connection. So we can see how the pandemic, within the pandemic, these issues may have affected older people disproportionately, with more older people socially isolated and in many cases not necessarily comfortable with technology. This, coupled with their risk factors, gives them an increased risk of loneliness. So loneliness and isolation are associated with many poor outcomes, with health outcomes associated with loneliness on par with the impact of smoking. Prolonged periods of isolation and loneliness are associated with mental health issues such as depression and anxiety, and social interactions actually require many neural connections and are quite cognitively complex. And as such, social interaction is actually protective for factors like dementia, frailty, and functional decline. Loneliness and isolation are also associated with poor physical outcomes such as high cholesterol, blood pressure, cardiovascular disease, stroke, and early mortality. To address social isolation, loneliness, and poor mental health in older people during the pandemic, Bolton Clark implemented the Hor-R-U program. This program is built on a pilot project led by Judy Lothian, where hospital volunteers provided 12 weekly telephone calls to socially isolated older persons discharged from the emergency department. This initial pilot program was a success and determined to be feasible and acceptable in this setting, and participants experienced significant reductions in loneliness and depressive symptoms. So during the pandemic, the version of Hor-R-U that we implemented at Bolton Clark was quite similar to this pilot program, but was adapted to Bolton Clark clients in both at home and in retirement living. Volunteers provide social support calls once a week, and they don't provide any specific psychological support. Instead, they provide general social support, building rapport and just chatting with their participants, providing many with a social connection that they might not have experienced. The chats are about 20 to 40 minutes in duration. And for this project, we partnered with volunteer organisation Friends for Good to handle the volunteer recruitment, coordination, and day-to-day social calls. In terms of uptake, as of last week, we had 157 clients and residents of Bolton Clark referred to the program. As you can see, the majority of these are women and just over half are located in Victoria, which given its extended lockdown period is understandable. In addition, the majority of our Victorian operations are at home support, so support within individuals' homes, which means that during lockdown, people would have been alone in their homes unless they lived with others already. We've made over 500 calls and the average call duration is approximately 24 minutes, although some calls are as short as 5 minutes. And we did have one call that lasted almost 2 hours. At this point in time, the average number of calls is around 5. We're continuously bringing participants on board, so this makes a lot of sense. And some people are very much enjoying the program because we do have a cohort of individuals who are who've had over 20 calls. Information from our volunteer call logs tells us that approximately 50 to 60% of participants indicated that they sometimes or occasionally felt lonely, and this did have some peaks, particularly when the Victorian lockdowns went into place, but are generally speaking fairly stable across the time. Finally, here we have some feedback from our Hor-R-U participants, which has shown that people are appreciating the program. People found that it was empowering and helped them to feel less alone. And importantly, it was seen as a good way of receiving social contact without having to leave the home, which was particularly important this year. Finally, some of the individuals indicated that they didn't want to necessarily admit that they were lonely, but they did find that the social support calls were a helpful way to chat with people and confide in them what they were feeling and experienced this year. So in conclusion, we've shown with this kind of initial information that the How-R-U program has been successfully transferred from the emergency department to the aged care sector within the context of a pandemic response program. And we have shown that the acceptability and feasibility appear to be maintained from the pilot program. We're currently undergoing a process of further evaluation, and this will help to garner some further insights and understandings about the experience of individuals accessing the program and its effectiveness. And it's our hope to embed this program as part of business as usual moving forward to assist those experiencing social isolation and loneliness in their day-to-day lives outside of the pandemic. And that's it from me.
Thank you. We've gone a little bit over on that one, and we didn't have any specific questions that have popped up, but if you do have any questions, can I encourage everyone to pop them into the Q&A, and we'll pass them on to Marissa either during the break or after the next session. She might get back in touch with you directly. Does that sound okay to you, Marissa?
Sure thing.
Excellent. Okay, well, our next speaker, who I'm hoping is online, I haven't spotted, oh, there we go. We've got Rebecca Jessup, who's joining us from Northern Health, where she's the Allied Health Research Lead. She's going to be talking to us about how do consumers find, interpret and apply health information during a pandemic, and how has this influenced their health-seeking behaviours. Welcome, Rebecca.
Thank you very much, Megan. And hi, everyone. I'm really pleased to be presenting this research to you today. We're very excited that we were able to conduct this during the height of the pandemic in Melbourne, and hopefully this research will lead to some changes in how we deliver health service at Northern Health. Just wanted to give you a little bit of background about Northern Health. We are the major provider of acute and subacute health services in Melbourne's north. And during the pandemic, at the height of the pandemic, about a third of people who were infected were actually in our catchment, and we actually had 10% overall of the Victorian people who are affected by COVID. We are a really diverse community, so about 165 different countries of origin are represented in our population, and we have about 100 languages registered within our health service. So it's a really diverse community. So this research was really led initially because we were really concerned about how our most vulnerable patients, so those who are high users of the health service, were accessing information about COVID and how they were using it to make decisions about how they manage their health. And we've seen during the pandemic that there's been a huge amount of false and misinformation out there in the media. And sometimes, unfortunately, that has come from some of our politicians and our leaders, and it can make it really difficult for individuals to make decisions about what they should be doing to prevent COVID, what the symptoms are, and what they should be doing if they suspect they have COVID. And some of the examples there were things like sunlight or using a hairdryer on yourself can actually reduce your risk, or washing your nose out with nasal spray. So we actually wanted to target a group of patients that were particularly vulnerable, and we used an algorithm called HealthLinks, which was actually developed by the Department of Health and Human Services, and it uses a range of criteria including age, chronic conditions, 3 or more unplanned admissions and ED presentations within a 6-month time frame, as well as a number of other different items to identify those who are most likely to end up attending ED and being admitted unexpectedly in the future. And it actually has a predictive validity of about 32%. So it's a pretty good way of identifying those who are most at risk. And we identified that about 5,000 people met the criteria for HealthLinks in the 2019 year. So it was pre-COVID we were interested in, because we wanted to see how changes had occurred through the 2020 pandemic. And what we did was we took a subsample of 200 of those, randomly selected and then stratified across languages. And we conducted 200 interviews, and 115 of those were in languages other than English. And we had 11 languages and 29 countries of origin represented. Oops, I'm going to go back, sorry, and just show you. We conducted, I've really lost it now. I can't get it to work. Sorry. All the joys of working with technology. So this is a time series analysis with those 200 patients, and it's actually representative of the whole 500 whole population sample. And you can see that they were attending regularly to the emergency department for the 14 months pre-COVID, and actually had increased their presentation rate. And you can see our avatar, who's just about to fall off the cliff, is demonstrating that once COVID hit, their presentation rates to ED just dropped away hugely. So we were really concerned about what was happening with this group of patients. So we went out using interview questions that were adapted from the WHO survey, Rapid, Simple, Flexible Behavioural Insights on COVID-19. And we wanted to find out how they were actually accessing information, whether they understood the information they were accessing, and whether they had actually changed the way they seek help because of what they were reading. And what we found, that across the cohort, the top 3 sources of information were television, internet, and then family. So actually 1 in 4 individuals that we interviewed used family as their primary source of information. We found that approximately 1 in 3 regularly relied on social media, and the top 3 areas or top 3 sources of social media were Facebook, followed by YouTube and WeChat, and that it was very dependent on your migrant background, which source you went to. So we found that those who spoke Punjabi were more likely to use YouTube, whereas those who were Mandarin were using WeChat, whereas our Arabic-speaking community were using Facebook. We found that people with limited English proficiency were more likely to source their information from overseas television, from social media, and from family, and that people that were under the age of 65 years were most likely to use the internet versus those over 65 who were most likely to rely on television. And we were a little bit concerned about some of our findings. We found that 1 in 3 individuals couldn't actually identify that medical care was one of the reasons that they were allowed to leave home during stage 3 and stage 4 restrictions. So our survey was actually conducted 3 weeks in stage 3 and 3 weeks in stage 4. We found that 1 in 3 respondents actually said that they had delayed or postponed medical care during the pandemic. So pretty scary stuff. And we actually found that there was a statistical significance between those who spoke a language other than English and those who were English speakers between those two responses. And you can see here that these are some of the long responses we got, that there was some very significant themes of fear and avoidance. So we actually had people who were reporting significant symptoms such as having heart pain, and that they weren't coming into hospital. But what we were surprised about was, and this actually reflects some of the research that was presented earlier this morning, that a huge number of these patients that we interviewed actually said that they were using healthcare differently, and that they were actually contacting their GP for support using the new telehealth item numbers, that now they communicated on the phone instead, and that they get scripts easily and do contactless pickups. And the general consensus was that, and this was actually 40% of the people we interviewed, that they were actually really appreciative of having this alternative method of seeking care. So what does this mean for for care beyond COVID-19? I think crises are always an opportunity to do things differently, and that many of our patients, and these are vulnerable patients who are high hospital users, have actually accessed care differently during COVID, and that perhaps the lasting legacy of the pandemic might be a flexible and responsive access to healthcare for our most vulnerable patients. Through rapid introduction and adoption of telehealth. And I just want to finish by acknowledging I worked with a very big research team. I also want to acknowledge the interpreting service, who were fantastic. Some of our interviews took an hour and 20 minutes, and they provided all that support free of charge. And the Office of Research, who were very supportive. We also received funding through La Trobe University, the Northern Health Foundation, and the 3 primary care partnerships that are in our region, so Inner Northwest, Hume Whittlesea, and Health West Partnership. Thank you.
Thanks very much, Rebecca. It's fascinating, really. Isn't it sad that we have to wait until there's an actual pandemic before we start addressing the access needs of patients and those properly? I'm hearing very similar reports back from some of our colleagues who work in cardiology services around the access of patients, and they've got real concerns for the mortality of their patients. Anecdotally, they're hearing that A lot of patients who aren't coming in for their regular treatments are actually ending up having heart attacks and dying. So have you had any access to, or have you been able to look up mortality rates for any of the higher risk patients and see if there's any changes there?
So interestingly, we actually haven't seen an increase in mortality rates at Northern Health for stroke and myocardial infarction. We've seen a significant reduction in presentation of about 15 to 25%. But we actually think that there is a genuine reduction in these events in the community during COVID. People are they're doing less things that are potentially going to cause those sorts of events, so they're not exercising quite as much potentially, and there's less circulating pollution, and they're potentially less stressed, and they also don't have the same amount of circulating viral illness that actually might lead to a pro-inflammatory response and result in more people having events. So we actually think there actually is a genuine reduction in those types of conditions, and that's why we're not actually seeing them at ED. There are, though, definitely there is a proportion of people who are avoiding care at the moment, and I think we'll see screening rates are way down, and we'll see people being diagnosed late for a lot of things after this pandemic, which is really worrying.
Well, thank you. That was a really wonderful talk. I really appreciated it. We'll move on to our next one now. Next, we're hearing from Angeline Ferdinand, who's a postdoctoral research fellow at the Doherty Institute in Melbourne. And she's going to be talking to us about lessons from COVID-19 on pandemic preparedness in pathogen genomics. Are you with us?
Megan, we're just finding her again. She's just dipped off camera for a moment.
Okay. Well, right. Did anyone have any last minute questions for Rebecca then while we find Angeline? I was going to say that I was very curious about the hairdryer and how it prevents COVID, but it's perhaps best that I don't ask about that. Maybe that's some of the information that they gleaned from Facebook or family.
Yeah, definitely not an accurate preventative for COVID.
Megan, I had one question for Rebecca, and it might be easier maybe if I ask it rather than type it and you ask it. And that was the name of the WHO survey that was used, because there are quite a number of experience surveys.
Yeah, absolutely. It was the rapid, hang on, I'm just pulling it up. The Rapid, Simple, Flexible Behavioural Insights on COVID-19. So we adapted it a little bit to our context.
Great, thank you. Okay, I just have from our technology host a message here. Just won't.
Bear with us with our technical issues.
Okay, Megan, our next speaker has some computer issues, so can we now go to Mary White, the next speaker in this session?
Have we got Mary online?
Yes, I'm here.
Oh, hello, Mary. So we've got Mary, who's a research officer and paediatric endocrinologist at the Murdoch Children's Research Institute. And Mary's going to have a chat to us about COVID-related opportunity to improve clinical efficiency and attendance. Thanks, Mary.
Thank you. Oh, sorry. So good afternoon, everybody. So I'm going to present this paper on behalf of my colleagues at the Health Services Research Unit and Department of General Medicine at the Children's. So the relationship between hospital outpatient clinic waiting list numbers and hence time on the waiting list and subsequent failure to attend is well established. Ooh. I'm not sure what's happening. And FTAs are a significant issue for the general paediatric clinics at the Children's. Unfortunately, our clinic scheduling processes can be inefficient at times for a number of reasons. The admin team receive large volumes of appointment queries daily. The nature of the booking system means that it's pretty hard to identify any upcoming empty appointment slots. It actually has to be done manually, and therefore we do have issues with filling slots which arise as a result of cancellations. We did an audit of FTAs at RCH, and so in 5,614 new patient appointments over a 2-year period, which was between 2017 and 2019. We saw an FTA rate of 24.5%, which was 1,374 missed appointments. And this was associated with a loss of potential revenue for the hospital in the order of over $250,000. Having an FTA at this new appointment point was independently associated with increasing time on the waiting list, so time from referral, and notably it conferred an 11-fold increase of ongoing FTA during the study period. And so FTA appointments represent a pretty significant burden on what are already limited resources at RCH. So the hypothesis for this initiative was that an intervention aiming to reduce waiting list times for new appointments is likely to have an impact on FTA rates at both the new and ongoing review appointments, and that this would confer a positive impact on clinical efficiency, clinical care, and hospital revenue flow. There isn't any data on FTA rates in paediatric clinics in Australia, nor any interventions to address them. The initiative I'm going to outline does align somewhat with Catherine Harding's stat work, which looks at specific and timely appointments for triage. So the waiting list pilot program was a clinical intervention. So this was set up as a clinical initiative rather than a research project, and took place over 1 day a week over a 20-year period. And this was between April and August of this year. It was conducted in a convenient sample of patients awaiting allocation at their first appointment for non-specialised general paediatric clinics at RCH. And while this was ongoing, routine clinic appointments allocation by our clinic booking administration staff proceeded as normal. I should say that the COVID pandemic, the changes in workflow due to the restrictions allowed us to do this in this time period. So the flow diagram for how the initiative worked was that starting at the person at the longest, who was waiting longest for an appointment, a phone call was made to the family, firstly to clarify that we had the correct contact details with an interpreter as necessary. And so we firstly determined if that child had already been seen for that same issue, either at another RCH clinic, at another institution with a private paediatrician, and if yes, they were removed from our waiting list. If not, the next question was to determine if there was an ongoing clinical need or a parental desire for the child to be seen at RCH, and if not, they were again removed from the waiting list. So the remaining children were assessed to determine if a telehealth appointment would be acceptable and appropriate. We then identified upcoming slots for the following week, and this information was fed back to the clinic coordinator who allocated the slots, and the cycle continued. So at commencement of the pilot in April, the general paediatric clinic waiting list comprised 1,060 individuals. So again, these were children who had been referred to the hospital and were awaiting clinic appointment allocation. And they had a mean waiting time of 392 days. During the intervention period, 531 families were contacted, and the number of patients removed from the waiting list was 113 for a variety of reasons, including resolution of the issue and being seen by another service or at another clinic. We identified that we had incorrect contact details for 33 families and had to obtain these from either the general practitioner or the referring doctor. So this is a preliminary report on what we've done, but so far, so at pilot conclusion in August, there were zero patients awaiting appointment allocation at the children's in the general paediatric clinic. As it's early days yet, but a review of the FTA rates in 2020 showed a reduction to 15% of FTA rates across the board in September, which was down from an average rate of 24.9% in the previous 8 months. The cost to deliver this intervention for a year 3 to 6 general medical registrar who was delivering the intervention at a 0.2 FTE over a 20-week period is somewhere between $8,400 and $10,000. And if we see a 10% reduction in FTAs, this would equate to a cost saving or a cost saving to the hospital in the order of $20,000. So it's a cost-effective initiative. But this is early days. So again, longer waiting times for appointments and initial and subsequent FTAs are inherently associated, and they represent a self-perpetuating cycle for both the clinician and the patient. The impact of this intervention I present today in terms of FTA rates will be evaluated and audited over time. And I suppose the questions we'd like to know is there a legacy effect of a short intervention, or is there evidence to support ongoing implementation of this model? And so this data serves to highlight the opportunities as well as the challenges that we've been presented to healthcare services, particularly in related to the context of the low burden of COVID cases we've seen in the paediatric sector to date, but also described elsewhere in the previous talks in this session. So I'd like to acknowledge my co-authors, but particularly Dr. Eva Sudbury, who conducted the waiting list pilot program and is now enjoying her maternity leave. And I thank you for your time.
Thank you so much, Mary, and thank you for being willing to jump in when our other speaker was having technical difficulties. We haven't got much time for questions, but I was just going to mention that it was interesting you said that there was no other research on paediatric FTAs that had been published or any other interventions that had been used to try and reduce it. I know for a fact that in Queensland there's actually been quite a bit of it. It just hasn't been published.
Yeah, yeah, we were aware of that, and yeah, it's a really good initiative. But again, yes, it's hard to report on the data, but yeah. Yeah,
and I think that's a really good message for people that, and particularly, I mean, we work as health services researchers, we work an awful lot with health partners. And there's often reticence to, you get to the end of a project and it didn't seem to have much impact, so you don't publish it. But I think once again, that's a really, really strong, please publish your research, even if you don't think it's of interest to you. It'll save everybody else a lot of work as well. So,
agreed.
We better move on to our next person, who we've now got online, hopefully, is Angeline.
Yes, she's online.
Hello, we've got Angeline Ferdinand joining us, who's a postdoc research fellow at the Doherty Institute in Melbourne. And she's going to talk to us about lessons from COVID-19 on pandemic preparedness in pathogen genomics.
Hi, everybody. Sorry about the technical difficulties. Thank you so much for allowing me to participate. It's been a fantastic event. So my name is Angeline, and I'm with the Microbiological Diagnostic Unit, Public Health Laboratory at the Peter Doherty Institute. And I'm going to be talking today about MDU's experience of comprehensively sequencing COVID-19 cases in Victoria and what can be learned for future pandemic preparedness. So from essentially the time that COVID-19 was first diagnosed in Australia, MDU has made the decision to comprehensively sequence all cases possible, which has led to the MDU SARS-CoV-2 sequence dataset being one of, if not the most complete globally. This has been really important in terms of being an international resource for understanding transmission dynamics, but also in enhancing epidemiological investigations and providing evidence to inform public health interventions in Victoria. Although the utilization of pathogen genomics in public health systems is increasing globally, the evidence regarding how best to invest for pandemic preparedness is lacking. Thank you. So this research has been conducted to examine MDU's, sorry, one slide back. No, sorry, I'm not sure how to.
Angeline, if you can just use your arrow buttons.
There we go. Thanks. So the research was conducted to examine the rapid genomic response to SARS-CoV-2 as an emergent pathogen and understand some of the contributing factors, and then to draw on that experience to provide recommendations about what can be done to improve the utility of pathogen genomics in pandemic preparedness. 15 semi-structured interviews were conducted with individuals that produced, disseminated, and used SARS-CoV-2 genomic information. And elsewhere, even where the capacity to undertake comprehensive sequencing existed, the decision wasn't made to do so. It was different in MDU because because of a few factors. Possibly the most important was this idea of comprehensive sequencing was seen as an extension of established practice. So you can see from the quote, on the bacterial side, we'd already moved to sequencing every sample. So it was a natural continuation of that policy. There was also recognition of what could be gained in terms of control of COVID-19 in Victoria. And there was also the existing,
Arrow keys not working?
Yeah, I'm not sure if it might just be my computer. So once the decision had been made, local relationships were really a driving force in enabling that work to be carried out. And one factor that was quite important was the co-location of the Victorian Infectious Disease Reference Laboratory with MDU, since Vigil was the initial contact point for COVID-19 samples. And with MDU just downstairs, as the quote says, it was really easy to say, okay, we'll redirect them down there and we'll sequence everything and see how we go. There was also the ongoing support of DHHS that had been established previously. So again, it was seen as an extension of support that had been provided for pathogen genomics up until that point.
Angeline, do you want us to try and move your slides for you?
That would be great.
Yes.
So just the next slide. Thanks. As well as local relationships, international networks were really important to allow this work to be done. Some of this was more established and traditional forms of disseminating information, but one that was mentioned quite frequently was the contribution of international, informal, and very flexible communities that were really built on openness and goodwill that had been established over a long period of time. So one of the bioinformaticians here is saying, look, they didn't really know what to do, but they had developed an online community on Slack with about 1,000 members. So they were able to go into this community and just ask people who had previous experience, what can I do? Somebody mentioned this tool and that tool, and they were able to figure it out. And they're saying this community was really critical. It wouldn't have happened otherwise. They've given and been open, and so people want to give back and return favors. And it's not one for one, it's one for many. Next slide. And finally, the existing capacity, workforce, and infrastructure of MDU provided a solid foundation for the laboratory to take up the challenges that come with a new pathogen. So this person is saying we didn't need to change the competency or type of staff. We could use our existing platform, and we had already established a high throughput sequencing platform. And there was the opportunity to take that and pretty much run with it. And in fact, the pandemic actually served as an impetus for projects that had previously been conceptualized. It's driven forward a number of things that we've been wanting to do for a while. Next slide. So in the very early stages, apart from the contribution to the response as the pandemic progressed, the rapid sequencing and sharing of data actually served in itself to improve the quality of sequence data at the beginning, in the beginning stages. So with the sequence data being publicly available, if we hadn't uploaded it, I don't think we ever would have become aware of this problem with the data. So we won in the end, and other people learned from our mistake. And in the beginning of the presentation, I spoke as well about how part of the motivation was to provide an international resource, which did come to fruition in the very early stages, also contributing to pandemic preparedness, even in other countries. So a lot of labs around the world were behind Australia, and they needed an example data set to test their pipelines on. So it actually improved a lot of American labs preparedness when they finally got genomics funding. And next slide. So 3 key recommendations coming out of this work. First, the importance of implementing strategies to facilitate the operationalization of open science principles and pathogen genomics, including governance skills to manage real or perceived risks of sharing data. as well as investing not only in so-called hard or analytical skills, but also skills that contribute to the openness, flexibility, and responsiveness in pathogen genomics, and funding to support open and data sharing platforms. Secondly, establishing strategic and sustainable partnerships, particularly looking to capitalize on existing strengths and approaches that bring together a wide variety of stakeholders, in conjunction with long-term investment underpinned by a coherent strategy. Of course, there continues to be exploration of ethical, legal, and social implications of pathogen genomics in public health, and these also need to be considered alongside any intervention, which also necessitates broad engagement. And next slide. Just some final acknowledgements of all people that participated in this research and contributed their time and expertise. And the research was supported by an NHMRC partnership grant. Thank you so much. And I'm sorry for any extra time that I took up.
That's okay, Angeline. Thank you. We just had one question, which you probably answered in your final slides, actually, with your recommendations. Rashid asks, in terms of your experience, how can the world better prepare for outbreaks caused by high impact respiratory pathogens? Is there anything you'd add on top of your recommendations?
No, I think that probably the recommendations cover it. I think that there does need to be, and there has been more investment in pathogen genomics, especially obviously with the pandemic happening. There's been a flood of investment in the area. But I think that it's really important not to focus only on, respiratory illnesses, because the fact is we don't know where the next pandemic is going to come from. We only know that there probably will be a next pandemic. So it goes back to what I said about really being able to be flexible to emerging pathogens and making sure that there is a broad spectrum and strategic investment in the area so that we are prepared for what comes.
And having those wonderful networks that you've built and the openness between countries must be an incredible help to that sort of thing as well.
Absolutely.
He's hoping the rest of the healthcare industry can, and maybe even our politicians can maybe learn a little bit from that.
Yeah, well, I think one of the things that really came out and was the importance of these, we talk about collaborations, but these are really communities, shared communities, which has been so important. So that openness to provide information without the expectation that, make sure that you, list me as co-author and that kind of thing. But the real generosity was a driving force in those early days.
That's wonderful. Well, thanks very much, Angeline. We will now hand over to HSRAANZ exec member Suzanne Robinson, who's going to lead us in a bit of a wrap up and discussion. Over to you, Suzanne.